today is to bring you the hepatocellular carcinoma in Indonesia and immunology consideration. I have nothing to disclose. Indonesia is considered relatively high in incidence of liver cancer. According to the Globocan 2020, liver cancer is the fifth most prevalent cancer in both sexes and all ages in Indonesia. In male, this cancer is the rank third, and the in 2020 in male liver cancer is ranked third after lung and colorectal cancer. For risk factors of HCC in Indonesia, the risk factor is a chronic infections of hepatitis B. This is the main risk factor of HCC in Indonesia since 1999, and also the survey in 2014 showed the same. The hepatitis B is the main risk factor in our populations. Until now, the risk factors for HCC in Ciptomangunkusumo Hospital or in our country is still hepatitis B. Other risk factor is hepatitis C, but the increasing number of people with non-B and non-C that may be regarding to fatty liver. The 1-year survival rate from our patients is increased from 24% in 1999 to 29% in 2014, while median survival decreased from 146 days to 138 days, although it's not really statistically significant. So after many years, the survival of patients with hepatocellular carcinoma in Indonesia does not get any much different. We do the primary preventions of HCC, such as the universal HPV vaccinations in all infants that already began in 1987 for all the babies. But maybe because it's not given at birth, the efficacy of vaccinations may be not really good. For secondary preventions of HCC, antiviral therapy of all patients with chronic hepatitis B and C infections to achieve HBV suppression and sustain virological response in hepatitis C. And we also do the surveillance of HCC with ultrasonography and tumor markers of AFP for 6 months in high-risk populations. For the treatment algorithm, we have our own modifications of treatment algorithm. For the first line is the same with the BCLC system, but we have second line treatment, which we implemented the SBRT, stereotactic body radiotherapy, and also the transarterial radioembolizations for the second line treatment. This is for patients with that cannot be able to do the first line or fail to achieve the response in the first line. The clinical pathological studies in our hepatocellular carcinoma showed that beta-catenin expression is less in our populations. Beta-catenin expressions were only in about 1/3 positive in our patients. And most of them, or majority of the patients, have a negative beta-catenin expression. And this is also related to the tumor size. Tumor size less than 5 centimeters usually have positive beta-catenin, and more than 10 centimeters have a negative beta-catenin. So the beta-catenin expression is significantly associated with low serum AFP and well to moderate differentiation. Strong nuclear beta-catenin expression implies better prognosis for HCC in our cases. So until 2021, the most common cases of HCC is in the BCLC stage B and also in BCLC stage C. Unfortunately, we have about 15% of these patients in BCLC stage D, which is can be offered best supportive therapy. But the treatment modalities cannot be given, in fact, to all of these patients because of the cost considerations. So liver transplantation, RFA, resections maybe can be implemented in minority of these patients, and still majority of these patients can be given with best supportive care. We know that the immunological aspect of HCC is very important. That some studies showed that the decreased effective T cells functions is important in HCC. So our study showed that the response of TH17, TH1 is in these patients, liver cirrhosis patients, and compared to the liver cancer, liver cirrhosis patients have more CD4 response. And after TACE, it can be shown that the TH17 response was better in patients with response to TACE, and also the TH1 is better in patients with in TACE response. So TH17 and TH1 significantly increase, as well as the TH1 in TACE response patients. And our study showed that the increased TH1 and TH17 after TACE may be regarded as an anti-tumor effect. And in this regard, we conclude that the plasticity of the TH17 toward TH1 may help the anti-tumor effects of TH1. And TH1 response is better in patients after TACE, in patients with TACE response compared to the patients with TACE non-response. So our study also showed that the treatment with local ablations may improve or may be influenced by the response of the immunology. For better treatment, we do the comprehensive liver cancer care in our hospital. This include the online patient discussion group to increase interaction between patients with cirrhotic and also the patients with cancer. Social media educations, performing educations, and also increase awareness and knowledge about HCC in cirrhotic patients. Also better surveillance program to increase the number of patients with abdominal ultrasonography and serum ART examinations regularly. And of course, correct diagnosis. We have a weekly meeting, a national hepatobacterial meeting, and comprehensive treatment by a multidisciplinary team. And this proved that our program is good, because there is a significant improvement in 1 year survival rate of HCC in patients with BCLC-A and BCLC-B from 48% to 73.9%. So, dear colleague, ladies and gentlemen, in conclusions, in our country, liver cancer, dominantly hepatocellular carcinoma, and it's the 6th most cancer cases in the world, and this is the 3rd most cancer cases in Indonesia, with domination of male gender. The recommendations of HCC surveillance are US examination plus AFP, or if available, can be also with the PIV-K2 measurement. The diagnosis of HCC based on clinical history, typical radiologic finding, and histopathologic finding. The treatment options is for unresectable HCC are local ablation, TACE, and systemic therapy, but cannot available for most patients because of cost consideration. And we show that the immunologic changes may be important in patients with after the treatment, and in this immunologic changes can support the result of therapy. So teamwork approach should be better for the management of HCC. This is to conclude my presentation. Thank you for your attention.